Hello, everybody, and welcome back to another episode of Legacy Running. I'm your host, Dr. Sarah. Super excited for today's episode as we are diving into what actually is going to help decrease your pain, even with that hip labral tear, that hip impingement, hip dysplasia, hip bursitis, anything really hip related. And I really wanted to dive into this episode because I hear of, and I talk to so many people who are just in that space of like, my hip is painful and I'm waiting for my appointment, or I'm waiting for my imaging result, or I'm waiting for the next step. And honestly, guys, I see and I help so many women phase, particularly people that are like close to me in Seattle, Washington, that are in this like acute phase. I have helped so many women as a physical therapist overcome this initial phase, which honestly cascades into the next phases as they are kind of overcoming their hip pain and getting back to normal life. So honestly, what I see out there is people like, oh my gosh, I have hip pain, and whether I know what's going on or not, they're just immediately like getting these blanket statements like, oh, I probably need to strengthen my glutes, or I need to lift heavier, or I need to do more core exercises, or I need to get this injection, or the only option for me is surgery. And while those are tools, I just think they're one part of the story. And I really want to like input some hope into just that phase of wherever you're at in your journey, of if you're feeling like there's nothing else left for me to do, or like I don't know what to do next. I really wanted to use this podcast to just kind of like attack the issue from start to finish. So working with many women that have hip labral tears, dysplasia, impingement, and want to get back to running. I just kind of want to give you my framework of like, this is how my brain works when I'm thinking of this woman is in pain to she wants to get back to running, of like how we're step by step going to do that, and just offering like some glimmers of hope in through there. And what this is not going to be, it's not going to be like a specific guide of like, okay, well, day one, you should do this, and day two, you should do this, and day three, you should do this. And these are the specific sets and reps, because you know what? Like, number one, that's medical advice. And then number two, like, that's not going to work. Like, I don't know you, and I don't know what your triggers are, and I don't know what propagated this in the first place. So then therefore we are not actually operating on like a plan specific to you, and the results are not going to work. So without further ado, let's go into the framework of how I like to decrease pain for my clients that are dealing with hip pathology. So say something that is going on in the hip. And this first thing maybe seems arbitrary, but honestly, like, I'm going to give some nuance to it that I think is going to be insanely helpful, or extremely helpful. So step number one is going to be identify a diagnosis. Okay. You're like, well, no, duh, Sarah, like that's why I'm getting my MRI, or that's why I'm going to do these things. And what I'm going to say is that I have nothing against imaging. I think it's an amazing tool, specifically too, if we're looking at the hip and we're thinking of potential bone stress injuries or stress fractures, which is kind of clumped into that case. And like, there could be something crazy going on. Like, it could be cancer, or it could be a vascular dysfunction. Like, having that imaging, like, I am so for it, but I also am, and obviously I'm so biased, but like, for good reason, I love when gals that have hip pain are also getting that kind of PT diagnosis. So there's literally nothing like walking into that office and just getting to know what is going on at your hip and having the understanding of it. Honestly, at the end of the day, like, that is what people want more than anything. Like, that is why people are going into my Empower Hip program, not because, I am like the best in the entire world, or because I have the specific exercises that they need. They just want accessibility to understand what's going on in their body with where they're at now. But nonetheless, an example of this is this. So one of my girlfriends, probably a couple months ago at this point, literally just woke up one day and kind of was having some hip pain, and then it just got like drastically worse. And over the weekend, it just got worse and worse and worse and worse. And her husband was like, you just need to go get imaging. You need to go get imaging. You need to go get imaging. She's like, you know what? Yes, sure. Like, I'm welcome to do that. But she was like, I want to reach out to Sarah. I want to reach out to Sarah and just see what her thoughts are and like get some understanding of what's going on. So I literally did a house call. This is like, the 1900s, did a house call and got to her house. And honest to goodness, it seemed like she had a labral tear, like a very acute labral tear. Just she was like in a position of a bunch of external rotation, kind of like overstretched the anterior part of her hip, and like literally like was having trouble with walking, was having trouble with getting up and down, all of this stuff. And honestly, it was like, okay, in this time and in this exact moment, it's really hard to make a very, very specific diagnosis because you are in so much pain, like you're so acute that it's really hard to like parse out kind of which tissue is the most irritated. But these are kind of like my three different hypotheses, and it doesn't really matter what they are, but these are my three different hypotheses. And from there, this is exactly what I need you to do, and this is exactly what I need you to expect. And feel it's important to make maybe this delineation too. Like if you're working with a PT, like they can diagnose down to the tissue level, but it's going to be a PT diagnosis because obviously they don't have like X-ray vision. And then those findings can confer with your imaging. So maybe the PT is like, actually, this is more adductor tendinopathy, but your imaging shows like a labral tear, and maybe they're treating that as an adductor tendinopathy and it's getting better. Then it's like, great, amazing. Or maybe they get that imaging result and it's like, oh, this is a labral tear. And then they're going to treat it a little bit more like a labral tear and then you're getting better. Honestly, it's just kind of like whatever makes you feel better in the end is honestly really what matters. But nonetheless, I was talking to her and I was like, you know what, you're too acute to come up with like a very specific, this is labral tear, this is adductor tendinopathy or whatever, because everything is just kind of sore. But I was able to be like, okay, right now, this is what I need you to do. Over the next couple of days, these are the motions that are going to be sore. If you're getting into that external rotation, this was specific to her. If you're like getting into that hip extension, like getting up and down off the ground, pivoting over this hip is going to be sore. Sitting in that like kind of butterfly, like crisscross applesauce position that you were sitting in, like these are the things that are going to be really painful for you. So when you're moving, try to go gingerly through these motions. And if you're kind of resting at this level of pain, this is how much it can increase. And this is when you know that you should need to like kind of sit down, take a break, back off. And then I kind of gave her a handful of like, I mean, yes, we can call them exercises, but they were just like simple, sure, we'll call them exercises, simple exercises that she was able to do to, well, number one, like rebuild confidence. Like her confidence is shattered. She's like afraid to move her hip in any way, shape, or form. But I'm like, hey, like if you do, like I had her do like standing glute kickbacks, and then I had her do, gosh, I can't even remember, like low back, right? Like low back, like kind of cat-cow situation. So she's getting some motion over the hip. I don't remember what else I had her do, but like 3 things. And I was like, these are your 3 things. And honestly, you're just going to go through the range of motion that feels comfortable. Let's try like 3 sets of like 15 to even up to 30 for these specific motions that I gave her. And what that did was it immediately calmed her brain. Like immediately in this moment where other people are waiting for an MRI and they're waiting for the doctor's appointment, she specifically had power to be like, okay, I know if I pivot, if I sit crisscross applesauce, and if I walk really fast, those are things that are going to activate me for right now. And I know that I can do those things, but I just need to move slowly or maybe anticipate that they're going to be sore. But right now in this phase of my life, I know that these 3 things are comfortable and they're like good for my hip, because when she does them, she felt better. So having that initial diagnosis wherever you are at, or just kind of understand, let's just even say like understanding of what's going on, is going to be so key. And working with that PT, so she's working with me and she was able to make marked progress. She actually didn't end up going to the doctor because she, like, spoiler alert, got markedly better. But if she went to a doctor, we would be able to confer those findings together. And like, I would be able to collaborate with the doctor and be like, okay, they'd be like, this is what's going on. This is what's going on, at MRI level, whatever. And then that would just help my findings and help me even more. Like, let's say we found out that it was a bone stress injury. Well, it'd be like, great, none of her exercises were weight bearing, perfect. Let's just like kind of follow whatever your protocol is, doctor. And then as we know that she has this, then we can like work on a progression protocol if this was a bone stress injury. So like, I just share this fact because I share this kind of step because I think so many people are sitting around waiting for the next step, but you really can like operate and not operate, but you can create some action and know some things of what to do. Maybe you're not going to feel 100% better, but like, wouldn't it be amazing to just know like, okay, these are the things that I think are going to be sore and these are the things that are going to help me. So that's phase number one, is just understanding what's going on, getting a diagnosis, working with building your medical team to allow you to have the best outcome. Moving on to step number two, this is what I call activity modification. And this can come in really any shape, form, or size. But if we are kind of going back to that last scenario with my friend who, we'll just say she had a labral tear because that's honestly what it seemed like. They had a labral tear. She has two young kids. So she has like a 2.5-year-old, 3-year-old, and then she has like a newborn who was like 6 months at the time. And she's like the full-time caregiver. So her husband works full-time and she needs to be able to like get up and off the ground. She needs to be able to feed her child. She needs to be able to like take her child to the park and go to do these certain things. And what we did in that session together was just like, okay, these are the things that you need to do. I was like, I think I just asked her, I was like, what are like the main things that you need to be able to do to like take care of your children and, you know, take care of yourself and be safe and all of this stuff. And she was like, well, I need to be able to like lift the car seat into the car sometimes. Like my husband can help me sometimes, but I need to be able to do it, you know, frequently, or at least once or twice a day. I need to be able to like, at least like sit down in a position to feed my daughter. And I need to be able to like walk around and help my son and like be able to pick him up, you know, during these times. And we literally just were able to be like, okay, these are the things that you need to be able to do. Like, let's go over specifically how you can do them with the best body mechanics, so that when you're going through these things, you're not like royally pissing things off and then you're like in more pain in that time. And again, like, nothing is necessarily markedly changing about her pain, but she again is in control of what she's able to do. And then therefore she's able to go through her day a little bit better. Also in this phase with activity modification and even like kind of the diagnosis of where we're at, I like to give a little bit of a like heads up of what's next. I'm like, hey, this is where you're at now. In maybe 2 to 3 weeks, you should feel better. Okay. Like these things just should feel better. Like slowly over the next 2 weeks, you should just start to feel better with these things. And if you're not really markedly ramping up and like doing things that aggravate you that are going to really royally piss things off, you should start to feel better. Okay. So this is kind of what we talked about this is kind of like her initial phase. This person was really coming in like with a high amount of acuity. Now let's go through, before we go through step number 3, let's go through someone who is maybe a little bit more advanced. Okay. And then we'll go through step number 3. So step number 1 is going to be like kind of like that diagnosis or understanding where you're at. If you're a person who maybe you've been through PT and you are like back to running, but you're like, gosh, I'm not like totally back to running. I'm not like, I'm still having pain once I'm running, whether it's 5 minutes or 20 minutes or whatever, we still need to understand where you're at here. So one of my clients, she came into the Empower Hip program. She was working with physical therapy, was kind of at the tail end of it, and she was still having pain with running. So she came into my coaching program and we looked at her mechanics specific to running. And what we found was that she was still having a ton of lack of hip stability with just basic mechanics of running. So single leg stance, single leg squat, single leg landing, like those things were so incredibly wobbly. So she was having a lot of excess motion at her hip. And then therefore, when she was going to go for her run, she potentially was getting a lot of excess rubbing at that hip labrum that she knew was torn because she got the diagnosis previously. And it was just really sore for her. And then she would have a lot of tightness into her adductor and into her abdominals after running. And we were able to be like, okay, where you're at now. So her, not necessarily her diagnosis, but just kind of like where she's at now was like, number 1, she still had a ton of lack of stability, even though she went through physical therapy with single leg stance, single leg squatting, single leg hopping. And we were able to identify where she was at running wise. We really found that she just was not comfortable with continuous running. She was still at that run walk phase. And we were like, perfect, amazing. So we move into the next phase and we said, okay, activity modification, you're actually fine with like pretty much everything of your day-to-day life. But I always ask people it's like week 2 of the program, or honestly, it's week 2 of the program. I have people fill out a heat sheet. So it's their hip, easers, aggravators, and tolerance. So we're just seeing like, hey, is there anything in your daily life that is actually sore for you that you maybe are not thinking about or kind of blowing past, and then you're like irritated when you go for a run? For her, she has to like, she's a college student, so she has to like walk a ton on campus. She was typically fine with that, but like long walks would aggravate her. And then also like long bouts of sitting. So we were just like, your activity modification is like, okay, if you're like, just like modify or be aware if you need to go for super long walks across campus. If you need to do that, maybe let's just map that out and plan that out a little better. And then if you need to sit for a long period of time to study or work or whatever it is, let's just make sure that we're getting up like once every hour for the next 2 to 3 weeks. Like, let's just make sure that that is where we are at. And then with running, instead of just progressing her running plan every single week, we said, let's just pause. Like, let's just stay where you're at and let's do 3 bouts of interval running. And then maybe we can do 1 bout of continuous running. And let's just, in terms of activity modification, let's just keep you where you're at here until we start to see that feel better. And then we can start to progress. So you can see if you're really acute or if you're further along the journey. It's just really important to like, as number 1, establish that baseline. And then number 2, not blow past all the things that you like need to do, or not blow past things that are aggravating you, so that when you go to do the things that you want to do, like run or care for your kids or whatever, you're not like in a lot of pain. Okay, so step number 3 is going to be specific exercise. I wish I had like better names for these because they're normally like a fun acronym, but like I just did it. So number 1 is baseline, number 2 is activity modification, number 3 is going to be specific exercise. Okay, so let me tell you a quick story here. I remember being a physical therapist on the island of Kauai. Okay, and this person came into me, and they hadn't seen another physical therapist at the practice that I was working at. And for some reason, they got on my schedule, and I was like, great, amazing. And this guy, he had shoulder pain. Actually, yeah, he had shoulder pain, shoulder problems. Like he basically was just like, my shoulder's super weak. Like I just feel like I was bench pressing, something popped, and my shoulder just feels super weak. And I was like, well, what have you guys been working on? And he's like, oh, well, the physical therapist here was working on like, my shoulder's been kind of bothering me. So like he said that I, have some like imbalances in my shoulder. And so we're kind of working on like core strength and like, we're doing some like shoulder stuff, but we're really like working on core strength, because if I don't have good core stability, then like my shoulder's like not really going to be functioning how I need to have that happen. And I just was like, what? Like, what? I was like, okay, let me just like back up this train of thought a little bit. Okay, so your shoulder, you were bench pressing and your shoulder popped and you haven't regained that like stability. So you feel like really loose in your shoulder and you're still feeling that. And we're working on core stability. And I'm like kind of like looking in and investigating. And I just was like, okay, I like anytime I'm like filling in for someone, I'm just going to do a quick assessment of like where they're at, like where this person is at today. I'll even do this with my own patients of like quickly looking and seeing where they're at for that day, so that therefore like my treatment is specific to that day. But I'm like, as I'm like just doing my general assessment for this person, I'm like, okay, so you have like full range of motion. That looks good. But when I'm like going to like give you resistance into these things, you have absolutely nothing. Like there's nothing to give in these certain ranges of motion for like these certain muscles. And I'm looking at this person and I'm like, I think you tore your rotator cuff. Like, I'm like, I think you completely have a complete tear of your rotator cuff. And like, based off of your, the subjective information that you told me, if there was a pop and then it just wasn't even painful anymore. And now you have absolutely a full range of motion and it's not painful, full and painless. But like when I go to resist, there's absolutely nothing there. Like I'm putting this whole story together that like I think you have a torn rotator cuff. So I said, I think you have a torn rotator cuff. I'm going to fax this information, like this updated information, to your local doctor. And then therefore, like, I think I'm referring you back for imaging, because like you've done, they've done like 8 weeks of physical therapy, if not 12 weeks at this point, and it hasn't made any progress. And I'm like, number 1, we haven't made any progress. Number 2, I think that this is completely torn and we need to just check in with your provider on this. Literally, he goes to get the MRI like quickly, like he got it like insanely quickly. Like I want to say like within the next week, and he was like, I have it fully torn. I think it was like supraspinatus or subscapular or something like that. Like absolutely fully torn. And I just was like, this is why we need to do specific exercise. Like in the beginning, we need to do specific things. Okay. So if someone's coming into me and they're like, my hip is painful, Of course, maybe in that beginning stage when things are really, really, really sore, maybe we're working around the joint. Like with that first person, I'm doing some back things or I'm doing some hip things. Like similarly to when you have an ankle sprain, if it's really swollen and it's really sore, we're not going to be doing single leg strengthening. Maybe we're doing ankle pumps and maybe we're doing some glute stuff just to like keep like glute kickbacks to like keep that like whole kind of chain engaged. But we're not like really getting after the ankle, but really as soon as your ankle is able to handle walking on it and load, I'm going straight to the ankle. Okay. I'm going straight to the ankle stability. I'm not doing core stuff. I'm not doing back stuff. I'm doing ankle stability. Like zooming out later, that will come. But right now we need to be really specific to what is going on. So let's kind of just walk through both of these scenarios. So for the first gal that was my friend, had the really acute hip issue, so on and so forth. For her specifically, she actually she just got better and like didn't really think about it, didn't have time to think about it. But for her specifically, like if I were to continue to work with her, I would want to see like, okay, well, this happened. I'm assuming that there's going to be like more laxity at the hip joint or more like less stability at the hip joint. So for you specifically, I want to like work on things to regain stability and regain your comfort with like loading that hip into a full range of motion, and being able to just be really confident over that side. So let me just be less vague here. If she had a hip labral tear, I'm suspecting that she would probably feel a little bit less stable on that side and a little bit less confident and comfortable. So maybe I would look at two things, I would look at more than two things, but broadly speaking here, maybe two things I would see is like when she squats, she's offloading that side. She's not able to get down as comfortably. And then maybe she's also like when she's on a single leg and doing motion, she's just not as stable on that side. So I'd be like, okay, let's do like a supported squat where you're like holding onto something and you're able to like equally load into both feet. So you're getting really, and you're able to go to a far depth down. So you're able to really load comfortably through that full range of motion. And then let's do something that is working on stability, like quadruped, hip rotation or like hip airplane or like a banded hip rotation thing. It's just something very, very specific to where she's at now. She's no longer in like that acute pain, but now she needs to start working on maybe some of the deficits that have occurred because she has injury. And newsflash, every time there is an injury somewhere, there's going to be deficits. Our body is like trying to it's trying to keep moving. It's trying to keep hunting and gathering, and it's trying to just go for it. So it's going to turn off certain things that are not helpful. And then just your body's just going to compensate. Everything else is just going to compensate. So if we don't reverse that, you're always going to operate in that capacity. Okay. So just making sure that we know that. And then looking at my other client. So this gal was the gal that has a labral tear, is the college student, was able to run, not super comfortably, and had a ton of just poor stability. For her specifically, once we like figured that out in kind of the baseline phase, and then we worked on her activity modification, which was just basically getting back to running that interval running and not overdoing it. Okay. So for her specific exercise, we weren't just literally at PT. They had her doing like, again, clamshells. They had her doing like reverse lunges. They had her doing like balance stuff. And I was like, that's fine. But I was like, you're still presenting extremely wobbly and extremely poor control. And those things aren't actually progressing you anymore. Like they could, not that lunges can't, but it's like they weren't, So what we did for her specifically was we worked on that. We worked on, similar to the first person I was talking about, we worked on single leg squatting with some support. So maybe she had her other toe down and we're working on, okay, you're going to sit all the way down and you're going to come all the way up and you're going to really focus on keeping that knee nice and forward instead of having it wobble all over the place and having your ankle wobble all over the place. For her, she had like a lot of lack of trunk stability. So we gave her like a trunk exercise that was able to work on her stability with that. And then the last thing was she had the lack of ankle and hip stability. So I gave her like a hip airplane, so she could work onto that into rotation. And honest to goodness, we were for both of these gals, like this is a very important part that is, I think, just so grossly underrated of like, we're not doing random things every week. Like when both of these people come to me and they're working with me, every single week, their program is the same. Like, hear me again. Like every single week, their program is the same. And only if something looks better or looks and feels better, or it's starting to feel like subjectively easier, then we're progressing it from there. So when these people come into me and they're working on like the, they're working on the squat with support, and we're working and getting both hips to go all the way down and be comfortable, then, and if maybe we're doing that for 2 weeks, then we're progressing it to a single leg and we're seeing with some support. And then we're progressing it to no support. And then we're progressing it to hopping. We're doing things that look and feel like the art of running, so that when they go to run, their body's like confident and comfortable and can handle it. We're also doing it with dosages that are pertinent to running. So 3 sets of 20 in the beginning, like maybe we're starting less, so it's not painful, but then we're progressing up to that endurance dosage of 3 sets of 20, so that their body is really able to maintain really good form for a long period of time, and then they're able to become more comfortable. I think a lot of people also feel hopelessness in this stage when they're working with PT, or maybe they're done working with PT, because I just see it all the time where their program is all over the place. 1 week they're doing plyos, 1 week they're doing strength training, 1 week they're doing clamshells, 1 week they're doing bridges. Like, and if they come in and they're in more pain, it's like, okay, well, let's just try all these new things. Like for me, I'm like, I want to bake the best chocolate chip cookie ever. So every time I bake it, I'm using the same recipe. And if I want to taste more vanilla, that's what I'm tinkering. If the cookies came out too dry, okay, then I'm like maybe adding more butter next time. Like, but I can't change everything every time and expect that my chocolate chip cookies are going to get better. Okay. Like it's very, very important that if you don't feel like you're making progress with the programming or the exercises or the rehab that you're doing, I mean, there's multiple factors to this, but it could be that your programming isn't specific to where you're at, and it's not specifically progressing every week for you to get the results that you want to see. Okay. And honestly, that could be true of me and my clients too. Like I have had people that have been doing certain exercises, and after 3-4 weeks, they weren't making any progress. I had a client like this not so long ago. She was working on a lot of that single leg stability stuff, and she just wasn't making any progress. And so we kind of actually switched things, and I was like, hey, let's switch these 2 exercises and let's actually get this to focus a little bit more into like the low back, hip flexors, core region, and work on some stability and control and even strengthening her endurance through there. And she started to make massive progress. So it's an art of being consistent and like doing the same thing, and also knowing like when it's time to change things up if things are not getting better. So hear me when I say, if you feel a lack of hope in this phase, when you're like back, or you're like trying to get back to running and you just feel like you're not making any progress, it could be that your exercises aren't specific enough, or your plan isn't specific and not similar, but maybe it's just changing too much and it's not specific to you. If that is the case, would love to chat. Feel free to look in the show notes below for the Empower Hip program. I'm going to be taking a couple one-on-one clients for the months of April and May, and honestly would love to help you kind of curate a program that is really specific to you, and use these principles for where you're at now. Okay, so specific exercise. Honestly, I've done so many podcasts on this, and we don't need to like dive into that more. But first, we started with like kind of establishing where we're at with that like kind of diagnosis, or just establishing baseline. Number 2, we looked at activity modification, so just not blowing up with where you're at. Number 3, specific exercise. Step number 4 is going to be that reverse activity modification. Okay, and honestly, I feel like this is where rehab can oftentimes cut you off, I feel like this is sometimes where rehab can cut you off. I remember when I was going into PT, I worked at a PT clinic and I had insurance for a PT clinic, and I needed to get approved to do more than 6 visits of physical therapy. I think I had used like 6 of them. I had used them. And I think I was back to, I don't know, some semblance of running, but like nothing like I needed or wanted to be. And I needed to get approved for more, but I was just progressing too well, and they cut me off. So I think I got like 2 more visits of PT. So I got 8 visits total, and I wasn't able to get more for this issue because I was back to work and I was back to driving, but I just wasn't able to run more than 20 minutes, which is frustrating. But depending on what your activities are, I like to think of reverse activity modification. So in that beginning phase, when my friend comes to me and she's like lifting the, carrier for her child in a specific way, and she's walking in a specific way, and I told her that for that period of time, like she was doing a bunch of like at-home strength training. And I was like, you really can't load this hip at all because it's not comfortable. Like just like specific, she's not much of a runner, but like specific, YouTube videos and whatnot. We like, if I was continuing to work with her, like that would be a layering back on of like, okay, let's do, these specific YouTube video, or let's do your YouTube videos, and like what kind of moves typically come up there. Like, are there deadlifts and lunges and like jumping squats and like so on and so forth. And like, let's list them out. Let's figure out which ones are in there. And then when you get back into it, let's be like, okay, in general, like these are the ones I think you could do great. Let's do like the squats and the RDLs, and maybe let's omit the jumping, lunges for this week and anything jumping for this week. And typically when people like to do workout videos, reverse activity modification tip is I'll just be like, move through it slower. Like if they're just going really fast, like it's okay if you're moving a little bit slower because you really want to just work on your form and control and not flare anything up. And then for my other gal, the reverse activity modification was just starting to increase her running again. So she was only doing run walk, which is great. I have nothing against run walk, but she just was like doing it for so long that she had built up, like she could run walk for like 45 minutes, but she couldn't run for like 10 minutes continuously. So what we did for her, and this was specific to her, but basically she did 2 intervals a week, and then one of the running sessions a week, we just had her do a continuous run just so it was markedly less than she was doing. So like 10-15 minutes, just so she could start to build her confidence that way. And then she could kind of grow in capacity in both the interval and continuous running with the like kind of acute to chronic workload progressions that I like to do in my program. And then here, other things that we could think about for reverse activity modification are like adding in the things that you like to do. This is something that I do with every single one of my clients, so in depth of like, I literally sound like a crazy person, but I'm like, okay, I get that you like to run, but like, is there anything else that you're like enjoy doing? I have clients that like to salsa dance, that like to hike, that like to bike, that like to, I have clients that like to elliptical, which is crazy. I love that they love to elliptical, or swim, or I'm trying to think if there's any other like unique things. I have like CrossFitting clients, climbing clients, stuff like that. And all of that is load to the hip that your body has to withstand the capacity for, or have the capacity to be able to do. So as we're thinking of going back into life, like if they're a runner and a CrossFitter, I'm like, okay, let's reverse back into those things and not just go into it and anticipate that you're going to feel absolutely amazing. So that's reverse activity modification. This is another phase where people really can get hung up again, because it's like, okay, I finished rehab and now I'm done. And then therefore I can just go back to do the things that I want. But then you just go back to PT in like 4 weeks because you did too much too fast and now it's sore. Okay, step number 5 is going to be flare-up plan. So this is like what I often call in my program the deploy phase. So if someone, or this is like great, we're kind of like entering the deploy phase. I have like discover, figure out what's going on, develop, specific exercise, activity modify, all that stuff. And then deploy is like when you're like out of that reverse activity modification, you're like back to doing what you want. And I really like to have my clients, we established it earlier, but I like to have them have a flare-up plan. And this is something that I think is amazing for you and your PT, or you and your coach, or whoever you're working with through this, of like establishing, okay, if I get sore, like if for some instance I did too much, or if I, just there was stuff outside of my control happened and now I'm sore, what am I going to do to make myself feel better? So are there like 2 specific motions that make you feel better? Are there, is it going to be a check-in with your PT? Like, that's great. I have a gal who came on my podcast and I've spoken to a couple of my programs. She has bilateral hip dysplasia and labral tears, and she maintains beautifully with strength training. She's able to run. She's run both majors. She's run multiple marathons. She runs half marathons, 5Ks. Like, she races and works extremely hard. If she has a flare up of her hip or her back, she has herniated disc also, she will just go to her PT, and like she probably goes to her PT, I don't know, like one handful a year, and just gets those like check-ins of like, okay, this is what I think you should do now. And then you'll just kind of get back to your maintenance program, but just understanding like that you kind of going back to that initial phase of like not just being like, oh my gosh, I need another injection. Oh my gosh, I need another MRI. Oh my gosh, I need another surgery. But like, no, like, what's going on with my hip? Like, what can I do? What can't I do? What's going to make me feel better in this moment? And being able to have the power and the confidence to move forward there. And then step number six is going to be maintain. So once you've understood where you're at, slash diagnosis, you have activity modified, you have done the specific exercises to rebuild specifically what you need. You've reversed activity modified, you have established a flare-up plan, then you can just enter into the world of maintenance. And the world of maintenance is wonderful. The world of maintenance is so fantastic because it no longer feels like I am always doing something for my hip every day or every other day. I need to be doing something for my hip, or I need to be so conscious of this, or I need to budget my miles. Maybe it'll feel like that for a little bit, but you really enter the space where you're like, okay, I know that at this phase, I can strength train twice a week. And when I'm strength training, I know that I need to maintain some sort of hip specific stuff that kind of go into these buckets. I know I'm me, like personally, like I know I'm a stability person. So I need to make sure I'm just doing exercises that are good for my hip stability. And I do those 1 to 2 times a week. I know that I do really well with running, gosh, anywhere from like 3 to 5 times a week. Even like 2 times a week is fine if if that happens. But I know that I do well with that. And I know that I just try to keep general track of my volume, make sure I'm not progressing too much too fast. And I know that my aggravators with running are like doing fast intervals uphill. So if I'm going to do that, I just am going to have kind of a plan to progress to that, or I'm going to progress to work towards that. Maintenance looks a lot like just maintaining and like kind of following a normal plan for runners, which that's super vague, but like typically would be strength training a couple days a week and then having some sort of plan where you're not like progressing your volume too much too fast. And yeah, I think just getting to maintenance is such a I think it's not talked about enough, which again is kind of out of the scope of this podcast of like once you're done with rehab, you don't just like stop and then because then you'll be back in like 6 months. But just having a plan of like non-scary or it's not scary, but what is the word? Like non-invasive. Like it doesn't like take a ton of mental load to do your maintenance work. Like whereas your rehab and your PT might feel like, okay, I really need to carve out the time for this. With maintenance, it's really like, okay, this is just what I do. It's kind of like brushing my teeth, and it just kind of naturally fits into what I'm doing anyways, if I'm already strength training, and if I'm already like wanting to participate in doing specific run amounts. So all in all, the steps are either diagnosis if you're kind of in that acute phase, or just figuring out where you're at if you're further progressed and already have your diagnosis, activity modify for where you're at, do specific exercises to rebuild up. Like don't fall for this BS trap of like, I need my core to generically be stronger and I need my ankle to generically be stronger. Like when in doubt, like assess, like get an assessment of figuring out what is your week with now, and then your steps should be specific to that. And then we want to reverse activity modify. So you're starting to add more of the things that you like to do, whether it's running, hiking, biking, skiing, weightlifting, whatever. Having a flare-up plan for if things go awry, so you're regaining control. And then number 6 is having a maintenance plan. So once you're done with rehab, or just getting back to the activity that you want to do, you are able to know how you're going to stay there forever and ever. I really, really hope that just having this framework allows you to feel more powerful in the situation that you're in. Again, so many women out there are dealing with labral tears, dealing with hip impingement, dealing with hip dysplasia, dealing with hip bursitis, tendinopathy, proximal hamstring tendinopathy, all capsulitis, all of these things. And so many people just feel so isolated and like there's no way out. I literally talk to people every single day that feel alone in this journey. And let me tell you, you're not alone. There's a way out. There is a step-by-step way out. If you are listening to this and you're like, oh my gosh, I need support, whether it's PT or you need online coaching or you just need someone to talk to, feel free to reach out to me, the Hip Doc Sarah, on Instagram, TikTok, Facebook, YouTube, all of the above. I would love to chat with you if you are interested in the Power Hip program, where I will take you through this, at least just establishing baseline and then kind of getting you back to that maintenance phase with specific exercise and run coaching. Feel free to fill out the application in the show notes for the Power Hip program. I will be taking more one-on-one clients really just this April and May, and I look forward to seeing you guys on the next podcast.